Thank you very much. Uh, when it comes to optimizing cardiorenal protection in diabetic kidney disease, what do we have? We always have been talking about AC inhibitor, ARB, and now SGLT2 therapy. Now, is it all? The answer, let us discuss from a real case scenario. This is a very classic patient who comes to our office. Uh, he has just come for a routine checkup, and when you find that he has been a diabetic 10 years, his HbA1c is now absolutely fine, 7.4%, and his office blood pressure is also good. So you think that he is really all well, and he says that he is feeling very good and he will be staying like this for many years to come. Now, this is not the notion, because as we know that he is one of those 74 million adults across India with type 2 diabetes, but he is likely to fall into 35 million of those 74 million who have CKD. So prevalence of CKD in type 2 diabetic across population is 48%. Now you want to say that no, you are not seeing this many patients with kidney ailments in your practice, but then it's an error. Why? Because the recommendation says that you need to check for albuminuria, which is very simple to do. Many labs do it, every lab do it in fact. And albuminuria is a simple, very important predictor of heart and kidney disease outcomes. So let's say when we talk about kidney, endpoint of kidney is to have a doubling of serum creatinine or end-stage renal disease or death. Now, if you look at just 1.5 gram of protein, the chances that he develops an ESRD in coming 3 to 4 years is about 40%. But if the protein is very high, then it is almost 90% chance. So if you do, and then the very important thing is here, Dr. Chirag has been talking about LDL cholesterol, but if you look at this, if you have a proteinuria of whatever magnitude, most of the cardiovascular events happen within 6 to 12 months. So very early. So the moment you realize that somebody has a significant proteinuria, he is destined to develop cardiovascular event in very early part of having proteinuria. So the guidelines now recommend that you need to look for both eGFR and albumin creatinine ratio at least once a year in all the patients with type 2 diabetes, because as we have discussed, looking for only kidney functions, looking for only glycemic control will give you only part information. Look for proteinuria, that gives you a overall view about what is his risk for developing cardiovascular disease and kidney disease. So now once again going back, I think I strongly suggest that all of the physician colleagues should keep these particular charts photocopy in their office to look at where a patient is going to go for. So now let's say this patient has come to our office, he is otherwise fine and he has no significant protein, he falls into category here. And when I categorize patients with diabetic kidney disease, I categorize like this: G1, G5 and A1. So like this patient is G2, A1, okay? Now, here as we have discussed, the protein part is less than 30 milligram per gram. But suppose if his protein is more than 300 milligram, he falls into this category. And as we have noted, it is a high risk for progression of kidney disease. So severely increased risk of CKD progression is here if we have a patient with a significant proteinuria. And significant, mind you, starts from more than 300 milligram. It's not grams. It's not looking at a severely increased protein of say 3 grams or maybe more. It is just above 300 milligram, it is significant. So then what to do? The recommendation says that you need to bring down protein excretion by at least 30%. How do we decrease it? we all know that by use of ARB. Now, when it comes to ARB, we know that we have a question about hyperkalemia. If you use AC inhibitor, 30% of patients of AC inhibitor will develop dry cough. So you need to monitor. And the recommendation is maximally tolerated dose of ARB. Now, this is a catch. What do you mean by maximally tolerated dose of ARB? It is not like you start with 40 milligram and look at BP reduction. If the blood pressure is within your acceptable range of say 85 diastolic, you think that now it is all that you need to do. No, it is not maximally tolerated. You increase from 40 to 80 milligram. If the blood pressure does not drop, you need to continue it at 80 milligram. So the one which does not produce any hemodynamic disturbance of any consequence or not produce so much of hyperkalemia, that is the dose escalation recommendation. So you can't do away with only 40 milligram of telmisartan or say starting dose. No, you keep on up titrating it to the point where patient tolerates it and you get the maximum benefit of reduction in proteinuria, which is finally the target. 30% reduction in proteinuria is desired, minimum. You should be getting it more but not less. So now when it comes to, as we have understood that presence of proteinuria heralds a adverse prognosis from both cardiovascular point of view and from kidney point of view. What do we have? And let us ask ourselves, what are the pillars that drives this? What are the mechanisms that drive this? One most important mechanism is hemodynamic, where higher blood pressure and higher intraglomerular pressure harms the kidney. It is also metabolic, as we know that advanced glycosylation end products and others harm the kidney. And the third most important mechanism is inflammation and fibrosis. This was initially not known to us, but now we know that this is equally important mechanism. And why? Because mineralocorticoid receptor overactivation is known in patients of type 2 diabetes, and overactivation may contribute to CKD progression by way of inflammation and fibrosis. What do we have for hemodynamic thing? We have AC inhibitor, ARB, calcium channel blocker, and we have SGLT2, which is also very important to know that it also helps in reducing intraglomerular hypertension. SGLT2, GLP-1, RS, metformin, and other hypoglycemic agent. So bottom line is that control blood pressure, control diabetes, but then also reduce inflammation and fibrosis. And that is to be attained by targeting MR activation, overactivation. So why there is a mineralocorticoid receptor activation is because of aldosterone, because of cortisol, because of RAC1 and oxidative stress, and also high albuminuria produces more mineralocorticoid receptor expression. So mineralocorticoid receptor activation and associated mechanisms are unaddressed and not a primary target with SGLT2 or RAS inhibitor. So mineralocorticoid receptor overactivation can be targeted upon with the use of finerenone. Finerenone produce MR activation blockade and homeostatic action. By that, it reduces inflammation and fibrosis. And you also address to the hemodynamic factor with blood pressure control and metabolic factors with diabetes control. Then you achieve heart and kidney protection. So the pillars now with various guidelines till date now say that the pillars are RAS inhibitor, finerenone, and SGLT2 inhibitor. Now finerenone is not the only medicine which is the new molecules are also under development. But the cornerstone is that you need to achieve this overactivation blockade so that you support the kidney and cardiac function to a point where it helps. And of course, it need not be told that you need to control lipid, you need to stop smoking and nutrition and regular exercise. These also are going to be the helping factors. So what is the so-called holistic approach? Holistic approach is you do all this, use ARB, use SGLT2, and this is upcoming. Probably time will tell us, maybe next IDCM conference in 2-3 years down the line, we'll learn more and more about, because semaglutide is now available in India and injectable counterparts are also coming. So how much help we get from this, probably we'll understand. But all these pillars So three pillars or four pillars, they are essential as a therapeutic tool to cut down onto the progression of both cardiovascular and kidney involvement. So when it comes to how are you sure about and what is the usefulness of this molecule, like let's say when it came to losartan trial, the number of patients were just 1500. When it came to canagliflozin Credence trial, which we keep on talking about, they were having about 4,400 patients. But with Fidelio, which was primarily targeted for kidney, and with Figaro, which was targeted for heart, cardiovascular events, Figaro plus Fidelio trials were for finerenone effect for the cardiac and kidney protection. And very large number, total if you sum up, it is more than 12,000 patients were studied to the endpoint. So it's a very large number of patients which has given us a very robust kind of data. And as we discussed, Fidelio was for kidney and Figaro was for cardiac, cardiovascular mortality reduction. So Fidelio trial was primarily designed for late stage CKD. What do I mean by late stage CKD? Where GFR was less than 60 ml per minute and there was significant protein excretion. And so Fidelio primarily represents a late stage CKD and the use of finerenone, whereas Figaro was primarily designed for cardiac protection and it represents the early stage of CKD. So if we combine these two, it comes Fidelity, where they have pooled analysis between stage 1 to stage 4 CKD. So considering all G1 to G4, this makes the whole algorithm of Fidelity. And our patients, if as we have discussed, he falls into this G2 and A3, so then he has a severe increased risk for progression of CKD. So now, Fidelity included patient, as we have discussed, type 2 diabetes across spectrum of CKD, and 40% of patient had albuminuria. In this, 40% of patient had albuminuric CKD with preserved kidney function. So their GFR was very well controlled. And what happened to them? Finerenone found that it improved cardiovascular and heart failure outcomes versus placebo, like hypertensive heart failure reduced by 22%, CV death risk reduced by 17%, and new onset heart failure risk was reduced by 32%. So definitely it was, along with other molecule, it helped in cardiovascular. What is finerenone? Finerenone is a bulky non-steroidal molecule. It has a very high selectivity for mineralocorticoid receptor, and it has a relatively short half-life, and it is less likely to produce hyperkalemia as compared to spironolactone. And the most important thing is the CNS penetration is practically nil, and sexual side effects are much less with finerenone. Finerenone downregulates WNT9A, which is a biomarker for kidney fibrosis. And what one have achieved by finerenone, very important, at age 50 years, the combined pharmacological treatment was estimated to lead to an incremental gain of 5.2 years from endpoint. Endpoint is like if you have a conventional treatment, let's say event-free survival was 10 years, whereas if you use, there is a gap of 5 years. So you gain 5 years of dialysis-free life when you start early. You gain lot of cardiovascular protection. All-cause mortality reduces by 3.8 years. So you gain a life spectrum of 4 years and dialysis-free life of 5 years if you use all the three pillars when you are taking care of a diabetic kidney disease. So finerenone demonstrated consistent heart and kidney benefit across various subpopulations, irrespective of atherosclerotic cardiovascular disease history or irrespective of whether patient was obese or non-obese, and regardless of baseline blood pressure. So it is a very time-tested molecule now, And how do we use finerenone? Finerenone should be started when proteinuria is detected and potassium is within normal range. One should not be using finerenone when GFR is below 25. So very important. Now, if you have a late comer to you, you can't use finerenone. You need to intensify it after 1 month when patient comes back to you for follow-up. And if his potassium is all right, then you can increase it to 20 milligram. If your patient's potassium is more than 5.5, you need to stop for a while. And once the potassium comes back to normal, then cut down dose from 20 to 10 and continue. Suppose if you have a patient who has been continued on finerenone and his GFR keeps on dropping, but then you can still continue till GFR comes to 15 and more. So the starting threshold is 25 and more, but even when the CKD progresses and GFR comes down to below 15, you can still continue till the GFR is 15. And what is my clinical experience with finerenone? Now, this is a very classic patient who is 56-year-old female referred to me because GFR was 41.3 ml per minute. Now, GFR, if you translate into milligram of creatinine, is obviously more than 2 because GFR has to come down to below 50 to have a doubling of creatinine, right? So, the patient was referred to me with this GFR and protein was 357 milligrams. So, here. Now, if you look at this, what is the risk? Very high risk. Now, this chart I keep in my office, so immediately I can make out that the chances of progression of diabetic kidney disease is very high. And she was on beta blocker, RAS inhibitor, diuretic, and SGLT2 inhibitor. So, this part was well taken care of by my physician colleague. I started this patient on finerenone. And when she came for the next follow-up, she came into category of A2, 198. There was a reduction in protein excretion. And if you look at potassium was well under control. And then the third follow-up, proteinuria reduced to 198. So there was 44.5% reduction. This is the target. You need to reduce protein excretion by at least 30% or more. And now, what are the 5 key takeaways for finerenone? When potassium is less than 5, start. Withhold treatment if potassium is more than 5.5. Starting point is where the GFR is more than 25 ml per minute or more. And it is likely to gain you a reduced risk by 20% and also likely to protect the heart and decrease cardiovascular event by more than 20%. So this is the usefulness of finerenone. With this, I end my talk. I welcome your question. Thank you.